Hello and welcome to an overview module of antibiotic allergy, a common problem that leads to manipulation and avoidance of antibiotics, which is a critically important issue in infectious diseases, but affects all providers who prescribe antibiotics. My name is Jackson Stewart, and in this module, we'll discuss the concept of antibiotic allergy, the common mistakes that are made in the assessment and management, and discuss how to approach an antibiotic allergy such that agents are not simply avoided, but the allergy itself may be reconciled. This talk is from an academic half-day presented to ID Fellows in 2021. I have no disclosures to report. Let's start with a clinical puzzle, which I think will elucidate a primary concept in antibiotic allergy well. Here we have three different antibiotic molecules, which are provided to patients in two different studies. In study number 1, in patients who develop a pruritic, generalized, and morbilliform type rash 7 days after taking drug A, about 20% also develop a similar rash around 4 days after taking drug B, and 15% develop a similar rash 3 days after taking drug C. Then in a second study, in patients who had anaphylaxis to drug A, 0 patients develop any reaction to drug B, but 15% of patients develop positive intradermal skin reactivity to drug C. So the question is, what is going on here? Pause the video to see if you can explain the results of these studies and the pattern of reactivity. This highlights a primary principle in antibiotic allergy. What you should notice here is that depending on the type of reaction, we get cross-reactivity between agents that is absent in other types of reactions. In study 1, patients who had a delayed type morbilliform reaction cross-reacted to all agents, but in the other type of reaction, cross-reactivity only occurred between 2 of the agents. That should tell you that there is a structural feature of the drug that is immunogenic for a specific type of reaction. For the delayed type reaction, this arylamine group, which is conserved across all 3 of these sulfonamide-like agents, but for the IgE-mediated reaction, only this isoxazole ring-like structure seems to be immunogenic for an IgE type reaction. This forms the basis of our understanding of antibiotic allergy, that we can predict cross-reactivity based on an understanding of important pharmacophores related to specific type of reactions. As an overview, antibiotic allergy is a very common and misunderstood problem in medicine. Not only are there very few allergists and immunologists trained and available for questions regarding these common problems, but fewer even are subspecialized and trained for drug-specific allergy. In infectious diseases, we certainly see enormous impact of this problem, since antibiotics are among the most frequently implicated drugs causing hypersensitivity. However, most clinicians see patients with antibiotic allergies on a daily basis and are forced to make decisions to navigate this problem. Unfortunately, blunt tools are used to get around the problem, i.e. simply avoiding these agents, but little to no effort is dedicated to reconciling these allergies and deciding if they remain relevant and if they can be challenged. This is a major deficiency and undoubtedly leads to patient harm. That leads us to our first key learning point. Don't just get around the allergy label. If we all had this attitude of someone else will eventually reconcile that or diagnose it or decide if it's still relevant, then no one will. And patients may go their entire lives without reconciliation. We should be looking at an antibiotic allergy label like a disease, one which needs proper diagnosis and treatment, and decide on every occasion if there is an opportunity for removing it. Although it may not be the most pressing issue today, it will certainly become a problem later. The scientific literature on the harms of penicillin allergy labels is robust and no longer debated. It is clear that patients with just the label of a penicillin allergy are treated differently, and this difference commonly leads to patient harm. This is probably mediated indirectly through 1, the delay in antibiotic therapy when deciding how to approach the case, 2, the selection of second-line agents with possibly less efficacy and more toxicity, and 3, the indirect effect of alternate choice leading to antimicrobial pressure promoting development of drug-resistant infections. This has been shown to lead to increased hospital length of stay and even worse overall outcome. That said, any of us who have any clinical experience know with some common sense that most of these allergy labels that we are seeing are erroneous and in fact not true. There is a discrepancy between how much penicillin allergy is reported versus how many patients truly will react to an antibiotic agent once it's administered. Historically, and unfortunately in medical school still taught this way, it was thought that about 5 to 10% of patients have a penicillin allergy, but we now know this to be false. Really only less than 0.5% of patients have a true IgE-mediated hypersensitivity. So what is the reason for this large discrepancy? Pause to think for yourself for some possible reasons. First, wrong diagnosis is the most common problem. Physicians and other providers simply writing rash on a chart without further consideration leads to confusion regarding non-drug related versus delayed type versus true IgE-mediated allergy consistently. Second, intolerances being inappropriately labeled as allergies leads to unnecessary avoidance of antibiotics routinely. And lastly, and third, we know quite well that true antibiotic allergies are lost over a period of years in a process of loss of sensitization. Therefore, allergies that may have been relevant are no longer so. This is rarely reconciled or recognized. Instead, antibiotics are instead avoided, sometimes forever. Another problem is the history taking and self-report of allergies by patients. Trying to remember details of events that have occurred years ago or were traumatic can be very difficult, and if significant time has passed, the accuracy of the report reduces substantially. Further, many patients will report allergies that occurred when they were too young to remember and rely on guardian report or memory. In these cases, we consider the reliability of these reports essentially negligible, and we should be seriously questioning the validity of these reports in our practices. Importantly, the semantics of the terminology we use is actually important, since even physicians and other clinicians use these words inappropriately all the time, which can confuse our patients, leading them to report on reactions to other providers in an inappropriate way as well. The term adverse drug reaction, of course, refers to any unwanted effect of treatment, which includes side effects, for example, things that we expected to happen but still are negative consequences. However, a hypersensitivity reaction is a distinct type of adverse reaction that must involve some immunologically mediated component, therefore either involving antibodies or cell-mediated immunity. Calling a reaction a hypersensitivity is less confusing than always using allergy, since often an allergy implies an IgE-mediated hypersensitivity, a specific type of reaction which involves either anaphylaxis, urticaria, or angioedema. We should start now with being specific when we use our terminology, especially when we talk to our patients about antibiotic-mediated reactions. Remember, of course, from school that there are many different types of hypersensitivity reactions. The Gell and Coombs classes divide them up by mechanism. The term allergy has traditionally been used and understood by providers to mean an IgE-mediated hypersensitivity, although some do not use it this specifically, hence we should. Really, an IgE-mediated reaction almost uniformly occurs in the first 60 minutes post-administration, whereas others are delayed type reactions, the most common type of antibiotic reaction being a type 4 hypersensitivity, occurring after multiple doses of drug have been administered. Let's take a look at a practice case to elucidate these important differences. Our first patient case is a 35-year-old female who has been newly diagnosed with HIV and is admitted for community-acquired pneumonia. She has started on ceftriaxone and azithromycin in the ED and tells you she recently started antiretrovirals and PJP prophylaxis a week ago. During our rounds, we noticed this rash, which is new as of yesterday. The rash apparently is only mildly pruritic, has a macular and papular component starting on the trunk and then spreading to the arms. The patient is not bothered by the rash. All of her blood work is normal except for HIV testing and a small leukocytosis. So ask yourself, what is happening here? As always, we should consider diagnosis here first before blaming on a drug, and if this is suspected of being drug-mediated, which drug is involved and how can we justify our answer? This is a case of a benign morbilliform reaction, the most common drug eruption caused by any antibiotic. This is a type 4 delayed cell-mediated reaction that can be more common in patients infected with immunomodulating viruses like some herpes viruses, in this case HIV. The presentation is most often a non-serious, mildly pruritic or even cosmetic morbilliform rash without systemic features, typically appearing approximately 5 to 10 days after starting the medication. This point is critical, since timing is important when deciding on the culprit. In the case we just discussed, the patient got ceftriaxone today but developed a rash yesterday, probably as a result of TMPS-MX administration for PJP prophylaxis. Importantly, serious reactions like DRESS should always be ruled out, but by definition, patients need to have nil systemic features or other problems with their blood work, making it simple to recognize this benign reaction successfully. Lastly, the most important thing to remember about this reaction is it is not life-threatening. In fact, it can be treated through, i.e., continue giving the antibiotic if it is the best choice for the patient. With very few patients reacting on subsequent challenges, if you notice a patient has a history of this type of reaction to an antibiotic, it is okay to give it again in the future as long as DRESS is not suspected. This type of reaction should be the easiest for us to delabel and reconcile. Which brings us to another important point we've illustrated here. Most reactions are non-IgE mediated. The benign morbilliform reaction is the most common, but reactions like a fixed drug eruption, SSLR, and others make up the majority of drug hypersensitivity reactions, not just to penicillins. If a reaction occurred after multiple doses or after a few hours of administration, it is delayed by definition. For our second key learning point, when we see the reaction rash on an antibiotic label with no other details, which is very common, the first and easiest move is to decide if this was a delayed or immediate type reaction. Most delayed reactions are challengeable and don't require avoidance. Severe delayed reactions are possible, but are easily identified with proper history taking. So the workflow for this could be the following. We suspect our patient actually has a delayed type reaction to an antibiotic. The first question we ask is this severe or a mild reaction? This, of course, would rely on your ability to be able to recognize and diagnose specific hypersensitivity reactions, which should be done when your patient has a known history of a drug reaction. If a reaction is severe, for example, Stevens-Johnson syndrome or DRESS, we should clarify the label with this information and continue to avoid. An allergist follow-up would be justified in these cases. But for all other cases of mild reaction, we should consider if there is an urgent need for this specific agent, in which case a treat-through approach would be recommended, supportively managing mild reactions if they occur, but often they do not. But if a non-urgent basis or if the diagnosis is in question, challenge testing is appropriate, i.e. giving a single dose and monitoring for that reaction. Now let's talk about a different group of reactions in our second patient case. This is a 45-year-old male, previously healthy, who was bitten by a friend's cat and develops a skin and soft tissue infection with fever. The patient endorses a history of penicillin allergy, specifically having had a reaction in 1990, so 30 plus years ago, where he developed an itchy rash about 2 hours after administration. He took diphenhydramine and the rash went away. The dentist told him never to have penicillin again for the rest of his life. The question is, what would be your approach here? If you're unaware for an infection like this, we typically prefer to use a penicillin antibiotic like amoxicillin clavulanate. Is this off the table? Remember that type 1 hypersensitivities are IgE-mediated, where B cells undergo isotype switching mediated by IL-4 or IL-13 release from T helper cells after being presented with immunogenic antigens. This causes systemic release of IgE antibodies, which bind locally to mast cells in the skin and basophils systemically, which, upon binding of the immunogenic antigen to these cells, causes cross-linkage of two IgE molecules and degranulation of cellular contents, leading to the classic features of type 1 hypersensitivity. This involves a reaction that almost always occurs within the first hour post-administration, but causes a unique syndrome on a spectrum of severity from isolated urticaria, an itchy migratory raised rash with central clearing, aka traditional hives, to angioedema, which involves periorbital or facial or tongue edema that can feel like throat swelling, which can cause some stridor and upper airway compromise, and anaphylaxis, a complex syndrome of systemic histamine release leading to multi-organ insult, but most commonly recognized as a combination of hypotension and either rash, respiratory compromise, dyspnea, or gastrointestinal disturbance. I said that true urticaria has been called hives in the past, but there is a large problem with this term. The word hives is used by providers to mean urticaria, but patients are not trained in this way. Patients have told me personally that they had hives, but then described them as black eschar-like lesions or even just as a morbilliform type rash. If you are simply writing on a chart what the patient says, then there could be a high risk of you misrecognizing a rash as true urticaria when it is not. Instead, ask specific questions when you are told about a rash to identify correctly its character and therefore its likelihood of being IgE-mediated versus a delayed type hypersensitivity. An important feature of all hypersensitivity, but better documented with IgE-mediated allergy, is the loss of sensitivity that occurs over years. As isotyped locked plasma cells die off in our bone marrow over years, we lose reactivity to antibiotics over time. This has been well documented, with about only 50% of patients retaining skin reactivity after 5 years, only 20% after 10 years, and approximately no patients retaining it after 20 years. Therefore, in patients with remote allergy, i.e. the reaction has occurred greater than 20 years ago without rechallenge, the risk of reaction on subsequent administration is about the same as the general population, or less than 1%. This concept is critically important and opens the opportunity to challenge and provide the best treatment to many patients. Perhaps that dentist was wrong and maybe the patient can have penicillin again one day. So what would the mental workflow look like for this in real life? First, we obtain a good allergy history, focusing on the specifics of the reaction and whether it required treatment, which specific agent was involved, knowing it was a penicillin-like drug is not enough, when the reaction occurred, after how many doses, and if it has been received since. Something like that can be looked up easily in the medical chart. That information alone can help us make the majority of decisions regarding what to do next, even if the answer is I can't remember or I don't know. Importantly, if your patient is nonverbal, proxies are great for gathering this information and can help remember critical pieces. For example, a family doctor or a husband or wife usually remember if the reaction nearly killed the patient. If based on this history, we are convinced this was actually a drug intolerance and not a hypersensitivity, we can delabel the allergy. As an opinion, there is no clinical utility to placing intolerances on a patient chart, since it would almost never change therapy. For example, if ramipril caused hypotension, we would actually know the drug is working. Or if penicillin caused diarrhea, it would never stop me from choosing this antibiotic if it was needed. Next, if the reaction was still unclear but had no features of an IgE-mediated reaction, challenge testing may be an option, just like with delayed type reactions. This leaves us with a patient with compelling features of a true IgE-mediated reaction. So what do we do then? In these patients, the practical decision on what to do next depends on how recent the reaction was, i.e. and therefore the likelihood that our patient remains sensitized, the severity of the reaction and therefore our ability to predict the severity of a subsequent reaction if it were to occur, and the urgency of need, i.e. if there are other options available for treatment or not. Considering these three factors, we can make a decisive move in all patient cases. First, if the reaction is very mild, for example, isolated urticaria or pruritus, and or the reaction was actually very remote, so even if it was anaphylaxis, if this occurred more than 20 years ago, we have the opportunity to consider a direct or graded challenge test, i.e. giving a dose and observing for reaction. This approach has been demonstrated as safe even in the office setting, so non-hospital setting, for carefully selected patients. Next, if a severe reaction is identified and it was recent, i.e. within a few years ago, but up to your judgment, and other options are available, but antibiotics are needed now, using a cross-reactivity table to select an alternative agent is appropriate. However, this doesn't solve the problem of the allergy label being in the chart, and patients in this group are good candidates for intradermal skin testing, which can be done in some centers in the inpatient setting, but most often in allergist outpatient offices. Lastly, there's going to be a group of patients who need the drug right now, but otherwise would have been avoided. So these are patients with severe or recent IgE-mediated reactions that this drug is the best option or the only option for a disease. In these niche patients, we can select desensitization, a commonly misunderstood medical procedure. Antibiotic desensitization is commonly confused for a challenge test, where a challenge test is used to diagnose an allergy, so we give a dose and see if they react, but we actually don't expect them to. A desensitization is for people we know have an allergy, but are therapeutically trying to push through it anyway. In this way, we actually expect patients to develop some degree of manageable reaction when undergoing a desensitization procedure, increasing the dose slowly over hours, an arduous process that leads to much nursing chagrin and patient dissatisfaction if done unnecessarily. Therefore, you can imagine the need to do a desensitization is actually rare and only should be done in niche circumstances when there is no other available option and we know the patient has a reaction. Let's try prescribing the right procedure with two cases. The first is a 64-year-old female with lymphoma receiving high-dose steroids for a long duration, and we consider the need for PJP prophylaxis. The patient has a history of TMPSMX rash approximately 10 days after starting, which went away without treatment and had no other features. What would be the right approach to that allergy label? In our case, it would be a direct challenge test, i.e. give TMPSMX 1 single-strength tablet PO times 1 and observe for a reaction. There would be no desensitization required, but I have seen it done for this reason. In our second case, a patient who has prosthetic valve endocarditis with Enterococcus faecalis, which is ampicillin sensitive, has a penicillin allergy 6 years ago, which involved anaphylaxis to piperacillin tazobactam, requiring intubation. So how would you approach this case if we prefer ampicillin to other options like vancomycin, since she has poor baseline renal function? This would be a good niche use of desensitization, since we would predict a bad outcome with full dose challenge of ampicillin in this particular case. Notice how our process first requires accurate diagnosis of the allergy type before we can plan our next move. In the first case, clearly a delayed or benign morbilliform reaction to TMPSMX. To reinforce once more, desensitization is not diagnostic, it is therapeutic. We should always confirm that our patient probably has an active allergy, IgE-mediated only, before starting this process. As a summary thus far, we've highlighted probably the most important concept in antibiotic allergy, which is accurate diagnosis. If we mislabel a reaction as IgE-mediated, we have set ourselves up to mismanage the patient for the rest of their life, until one of us decides to take it upon ourselves to reconcile exactly what happened. We will not know how to take the next steps. Many reactions can be rechallenged safely, and we should take the opportunity to do so at every interface of care. We touched on cross-reactivity before, but an understanding of how to select safe agents in patients with true allergies requires a knowledge of what we are reacting to. In fact, patients are not reacting to penicillin in IgE-mediated reactions. They are actually reacting to a haptenized form of penicillin, which is metabolized and binds to a carrier protein, becoming a molecule called benzyl penicilloyl polylysine. It is this drug protein complex which elicits an immune response, and this is important because the structure of the molecule that is capable of binding to the protein dictates the likelihood of safety with administration of different molecules. In fact, beta-lactam antibiotics are quite distinct. Although they are thought to share the beta-lactam core ring, this core ring structure is actually quite different between families of beta-lactams, i.e. the cephalosporin dual ring structure has a dihydrothiazine base, whereas the penicillins share a thiazolidine base. In addition, each beta-lactam may have an R1 accessory group, seen in the top left of the molecule, which vary between individual agents but may be immunogenic, explaining the cross-reactivity between specific cephalosporins. Understanding the reactive moiety forms the fundamental basis of beta-lactam cross-reactivity charts. For penicillins, the reactive moiety is decidedly the beta-lactam core thiazolidine ring. This means that all penicillins should be expected to cross-react, i.e. amoxicillin, penicillin, cloxacillin, and piperacillin. However, it also means that we would not expect cross-reactivity with cephalosporins or carbapenems. Cephalosporin allergy is almost certainly R1 group mediated, its dual ring structure being less immunogenic, which leads to cross-reactivities dictated by similarity in the R1 group, i.e. if a patient is cephalexin allergic, they can actually be cefadroxil allergic due to similarities in the R1 group, but they can also actually be allergic to amoxicillin, since amoxicillin also shares a common R1 group. Lastly, carbapenems are rarely implicated in any drug allergy, but in the few that are, it is probably core ring and conserved R1 group mediated, meaning that we would expect zero cross-reactivity with any penicillins or cephalosporins. The comment I most frequently get after presenting this is, but I've seen a patient who is allergic to penicillin and cefazolin. Shouldn't that be impossible? The answer is, of course, nothing is impossible. No patient has a 0% risk of hypersensitivity reaction. The question is whether or not it was cross-reactivity mediated, i.e., did we expect that to happen and therefore should not have given it, when in fact, patients with one allergy are more likely than others to have multiple drug allergies. I call this multi-drug allergy syndrome, but really this highlights the principle of increased propensity. A paper in JAMA found that patients with ibuprofen allergy were actually more likely to have penicillin allergy. Does this mean it was cross-reactive? No, it just means that the patients who have one allergy are more likely to have more than one allergy, and we would have no way of predicting that. In practice, we should pay careful attention to known cross-reactivities to ensure we don't unsafely prescribe an agent. But if reactions occur despite that, it is probably because of increased propensity to have multi-drug allergy and not cross-reactivity. Therefore, we should not avoid giving antibiotics for the fear of multiple drug allergy, which as of now we are unable to predict. There are many useful cross-reactivity tables available which highlight the R1 group mediated cross-reactivity behavior of cephalosporins, which may retroactively affect some aminopenicillins because of R1 group similarity. Some of these cross-reactivities are clinically proven, and some of them are only theorized based on their chemical structure. Either way, it is reasonable to avoid these cross-reactive agents, but there would be no reason to avoid agents in separate groups. Notably, cefazolin and cefixime have such unique R1 groups that they would be considered safe in any cephalosporin, penicillin, or carbapenem allergy. Remember these for when you're looking for a beta-lactam option that is likely safe. Remember, there is no risk of cross-reactivity, but rare multiple drug allergy is always theoretically on the table. To summarize our key learning points, first, don't just get around the label, find the way to remove it. You'll thank yourself later. Second, decide on the specific reaction that occurred with any antibiotic reaction, because this is necessary to decide on our next steps. Third, if this was a very remote reaction, the chance of remaining sensitized is extremely low for IgE-mediated allergy. Fourth, only use desensitization if it is truly required in a known type 1 hypersensitivity, and utilize knowledge of reactive moieties to make decisions regarding the possibility of cross-reactivity. I've also included some supplementary slides for your interest. Thank you for watching.